Hello, and welcome to tonight's program from Our St. Paul Learn with the League series. I'm Dr. Cheryl Bailey, and I'll be moderating the discussion tonight. Thanks to the Roseville area and White Bear Lake area leagues for lending their support. We'd also like to thank the St. Paul Neighborhood Network and Suburban Community Channels for taping the program tonight. The recording will be on our St. Paul League's YouTube channel, and we'd love for you to send your friends there and colleagues to watch it later. Before we talk about the League of Women Voters St. Paul, if you haven't seen the news, we have hard news to report. There's been another school shooting, this time in an elementary school in Texas. And although what we're going to talk about tonight is very important, we certainly send our prayers to the teachers, the families, the children in that elementary school. With respect to the League of Women Voters, we are a nonpartisan organization devoted to educating the public on candidates and issues, as well as promoting reliable and secure elections in our country. We study issues, we take positions, and we take action. So we would love you to check out our website. You can see it down there, LWVSP.org. Any interest in our league, we would love for you to become a new member. And we're learning today on the ancestral homeland of the Dakota and Anishinaabe people, and the current home of several Native nations, including the Dakota and Ojibwe. Land acknowledgement is only one part of supporting Indigenous communities, and we hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. We will certainly try to get to questions at the end of the program. By now, everyone knows if you are watching on Zoom, you've got a Q&A bubble at the bottom of your screen. If you're watching on Facebook Live, please use the comment section. We're going to really streamline questions to the program that we present tonight. And of course, we chose this topic because of the Dobbs v. Jackson case before the U.S. Supreme Court. They heard oral arguments in December, and we knew that the decision would come out in the summer. So months ago, we chose abortion as a study, as a program for us to present to you. If you are on the National League's website that you can see a snapshot of there, you can scroll down on this at home and actually listen to the oral arguments that were heard in December. So the National League's statement is that every U.S. resident should have access to affordable, quality health care, including birth control and the privacy to make reproductive choices. And I'm not telling you viewers anything new when I say that the topic of abortion can be very difficult for people to discuss. But there has been a lot of movement on this issue in every single state legislature, and the draft decision of the major case pending in the U.S. Supreme Court was leaked to the press on May 2nd. While it's true that the final decision might take a different form when it's officially announced, Justice Alito's document clearly states that the majority of Supreme Court justices fully intend to strike down Roe and Casey entirely. These decisions will affect every single one of us, regardless of age or gender. So in league fashion, we would like to take the temperature down, emphasize the history and facts about abortion in the United States, and let listeners and viewers make up their own minds in an educated and thoughtful way. There's just a Marist poll within the last 2 weeks, polling over 1,000 American citizens. And again, the decision is 64% of Americans would not like to see the Supreme Court overturn Roe versus Wade. Back in 2020, there was a Kaiser Family Foundation poll that showed 69% opposition to overturning Roe. There are many other polls you can find, and they can parse out regional differences, differences by age, gender, etc. But the overall number has stayed fairly consistent nationally that Roe v. Wade is not something that the majority of the American population wants to see overturned. And again, in league fashion, we'd like to try and give you our references as much as possible. So if you want to use your phone camera and take a snapshot of these, we'll try and have these available. Again, you can see the recording of this on YouTube again, and this slide will be there. But the majority of our statistics are from the Guttmacher Institute, you can see there, and the Minnesota Department of Health. Those are both websites that you can easily access yourself. And then literally the expert on the law with abortion in the United States is Professor Mary Ziegler, who literally wrote that book. That was published in 2020, and she's been featured on many newscasts, podcasts, etc. And then I draw your attention to our local paper, the Minneapolis Star Tribune. Before the leak of the draft, actually, on a Sunday front page section, they did a good article on abortion rights. And then the New York Times did a very good article on who gets abortions in America that you might want to reference, and that was December 14th last year. Okay, if we could start our talk to get you engaged and thinking about what you know really about abortion care in the United States, press 1, 2, or 3. You can see the choices there of how many. Oops, I'm not sure you can choose a choice. You can make a choice with that, or maybe you can. How many abortions roughly in 1 year are performed? Push 1 for 5 million, push 2 for 2.5 million, and push 3 for 800,000. And then of course there's a much smaller number to follow in Minnesota, since we're only a 50th. And I'm not sure if the viewers can see, but the numbers are coming in and you're pretty evenly spaced so far. We've got about a quarter of the people, now about a fifth of the people think it's about 5 million in the United States. About a fourth of you, 25% say 2.5 million, and about 56% are saying 800,000. So we'll move on, but we will, you'll definitely see what the results are, what the answer is. So again, I'm your moderator. My name's Cheryl Bailey. I did my medical school training in the University of Minnesota, and then I did 4 years of obstetrics and gynecology, followed by 2 years of GYN oncology fellowship. So although I never performed abortions, I learned a lot about contraceptives. I learned a lot about what happens when people are pregnant who don't want to be, and have had a strong affinity for this topic, of course. And then if I could give a warm welcome to our panelist, Dr. Carol Ball. Dr. Ball is a retired OBGYN who was the residency director at Regions Hospital, and then the co-director when the University of Minnesota and Regions blended their programs, co-director of that residency program. And importantly, she worked as an abortion provider for 40 years at Planned Parenthood. She's a member of the St. Paul League as well. So again, welcome, Dr. Ball, and we'll have to get moving since there's so much to cover tonight. Thank you for joining us.
Oh, it's my pleasure to be here.
For our audience, here are some numbers to the first part of your poll. Out of about 5.5 million pregnancies in 1 year, and this is in 2017 where the most complete numbers are available, 5.6 million pregnancies, 2.6 of them were unintended, and about 886,000, or 16% of all of those pregnancies, ended in abortions. And 93% of these were in the first trimester. And then they for some reason use 4-year intervals, but from these small intervals, there clearly has been a decrease in both the unintended pregnancies and a whopping increase in the abortion rate. So my takeaway on this slide, Dr. Ball, is just that it is so striking that half of our pregnancies in the US are still unplanned. So I'm going to give you that quote from Desmond Tutu when he said, "There comes a point when we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in." Do you have comments for us and for our audience about abortion, about contraception and helping women avoid pregnancy until they want to be pregnant?
Well, I think that one of the things that's happened, and we have seen a decrease actually in the number of unintended pregnancies and a decrease in the abortion rate over the last number of decades. And one of the things that's happening with that is that there have been improvements in the availability of contraception, both in the options that are available and also the ability to access contraception. The number of options have increased both in terms of prescription options and over the counter. And this also includes emergency contraception. There are a number of options available for emergency contraception, also known as the morning after pill. And as I had previously mentioned, access has also improved. There are fewer restrictions that women face to getting birth control, such as the need for a pelvic exam and in-person annual visit is no longer required. There's online prescribing. Some pharmacists are prescribing contraceptives. There are video visits, and also a number of school-based clinics now offer contraception. So it's clear that experts in the area of reproductive healthcare have really understood the importance of women being able to access the contraception that's available, and have really tried to remove as many barriers as possible so that people can get the contraception that they need and they want. Included also in the improvement in the options is very importantly the availability of long-acting reversible contraception, also known as LARC. This includes the implant, which is a little rod that's placed underneath the skin. And also now there are 5 different types of intrauterine contraceptives, also known as IUDs. Most of them are hormonal. There is also still a non-hormonal option as well.
Yeah, and you told me to keep with the look upstream option, that if people want to think about getting their elected officials to rally and legislate for improved coverage and improved access to contraception as part of healthcare, that would be something that our viewers could consider doing.
Absolutely, and we all know that the one of the Affordable Care Act provisions was that people should be able to access contraception without a copay, so essentially free. And we know, particularly in terms of long-acting reversible contraceptives, which are the most effective, they are as effective, if not more effective, than sterilization, both male and female. And that given the opportunity to get a long-acting reversible method for free without any cost, the majority of people will choose that option.
Yeah. Okay, speaking of men, my favorite question when I talk about abortion is the role of men, the role that men play in causing pregnancies that are unwanted or unplanned. And I would love to know if there's any medical research on male contraceptives, long acting reversible contraceptives for men. Can we use the phrase men impregnating women, for instance, instead of women getting pregnant? I see very little in the medical literature talking about male contraception. Any thoughts on this? Anything that you know about this?
Well, as you and I have discussed, this is something that gets brought up over and over, but has never really gained a whole lot of traction. There continues to be research on reversible contraception for men, but there are a lot of problems with making a reversible method so that men stop producing sperm. It has a lot of side effects. So there's really nothing that looks like it will come to market anytime soon. Although, of course, condoms are available and cheap, and they are about 85% effective. And they also have the added advantage of protecting against sexually transmitted infections. And let's not forget about vasectomy, because female sterilization is one of the most commonly used methods of contraception in our country. Vasectomy, which is male sterilization, is much less expensive, much easier to access, and has much fewer complications, does not require general anesthesia, and is an outpatient procedure. So that is something that men can certainly contribute when they are looking for a non-reversible method.
Well, we wanted to, in this program, sort of humanize and personalize the many thousands of women who seek abortions. That's 1 in 4 American women. And these are our family members, our friends, our neighbors from all walks of life, all religions. And there was a very good summary of this, and this slide is from the article in the New York Times by Margot Sanger-Katz et al. And they outlined the typical patient who comes in for a termination of pregnancy. They are almost always a mother They are in their late 20s. They've often had some college. They almost always have low income, unmarried, and in the first trimester. And this is more often than not their first abortion. And I was really struck by the poverty in this article. Can you give us your thoughts on the women that you care for and what what that article kind of told you about who gets abortions?
Well, I first of all want to make a comment about the 1 in 4 figure that you quoted, and just it illustrates how much the abortion rate has decreased and the unintended pregnancy rate has decreased in this country over the last number of years. It used to be, when I first began my career, that we said that 1 in 3 women in the United States will at some time in her reproductive life have at least one abortion. And it is down to now almost 1 in 4. So that's a really stark change. As far as the women that I see, the people that I see in my career, I've seen people from all walks of life and in all economic circumstances, including some well-known members of their communities who are quite prominent and seek private abortions. However, it's evident that people in marginalized communities, such as the poor, as is illustrated by this slide, and people of color are more likely to need to seek abortions. These communities have more difficulty accessing healthcare in all areas, not just the area of reproductive health. And this is a part of our well-known health disparities that exist in this country and in this state. There's also longstanding mistrust of the healthcare system, and particularly when it comes to reproductive issues. There's a history of forced or coerced pregnancy, as well as, on the other end, forced sterilization and a history of medical experimentation on these communities. So they are also hesitant and less trustful, especially when it comes to their reproductive capacity. Rachel Jones from the Guttmacher Institute has said it's people who don't have access to healthcare, access to contraception, who, when facing an unintended pregnancy, don't have the resources to have another child. So it's kind of a triple whammy for them.
Well, here's from the same article quoting the Guttmacher Institute, just that in addition to the overall fertility rate in the United States dropping, a 4% drop just in the last couple of years, the abortion rate is clearly decreasing. So some incomplete data show about 630,000 abortions were performed in 1 year. Again, can you comment on the decreasing rate?
Again, I think that that the data has clearly shown, and studies have clearly shown, that this is a result of better access to contraception. There are people who would point to abstinence-only sex education and that sort of thing, but that it also has been very clearly shown that abstinence-only education does not work, and that it is access to contraception that is resulting in these lowered rates of unintended pregnancy, and particularly rates of teenage pregnancy.
Mm-hmm. Well, let's switch to Minnesota data. So the second part of that poll question was how many terminations are performed in Minnesota. This is data from 2020, and the grand total was 9,100 women had abortions in our state. That's only 1.5% of the number performed nationally. And like most of the national data, the women are in their 20s and 30s. What do you see when you look at these numbers?
Well, I think it's important to also to understand that though the total is 9,108, this includes also women who come from other states. So it's not only the women of Minnesota who are included in this data. These are abortions that were performed in Minnesota. But the other thing that I see is that the fact that 60% of people who seek abortions are already parents, and that doesn't show up in this particular slide. But what does show up is that the vast majority of people who seek abortions are adults. They're 18 years and older. There are only 2.5% of the abortions that were done, as shown in this slide, were before the age of 18.
Mhm.
So these are adults who are making adult decisions based on the circumstances of their lives. Um, so I think it's really, really important to see that.
Mhm. Well, let's talk about the procedure itself. I think the details may surprise some of our viewers. Could you walk us through this for a first trimester termination of pregnancy?
Sure. And I want to also emphasize that in Minnesota in 2020, 90% of abortions were done in the first trimester, and nearly 80% of those were done at 8 weeks or less.
Mhm.
So I think that's also an important thing to keep in mind. For what we call a procedural or surgical abortion, we provide local anesthesia by a cervical block to all patients. And patients also have the choice of either mild sedation or they can have IV sedation. For medication abortion, and pain control is adequate for the vast majority of women using over-the-counter medications such as ibuprofen and Tylenol.
I am going to go to the next slide here. Tell us what the main thing is that women experience after that very early first trimester abortion.
The discomfort that women experience during the procedure is really variable. I've heard women describe it as no worse than a period. And I've also had other women say it was worse than labor. So that's it's all over the board, and everyone is very individual. Most women are able to tolerate the procedure very well with just the block that is given. The procedure itself, I used to tell women that it's from the time that I walk into the room until the time that I walk into the next room is anywhere from 10 to 15 minutes.
Mhm.
So when we say it lasts 5 to 10 minutes, we're including also the discussion at the beginning of the procedure, and placing the speculum and giving the block, and the actual procedure of the abortion itself is very short. Women, as I said, will experience cramping. They'll experience it, of course, during the procedure and then for a while immediately afterwards. But most patients leave the recovery area within a half an hour with minimal discomfort. And they stay longer if they have IV sedation. In fact, many women would rather just get up and leave. They don't want to have to go to the recovery room. They're ready to go.
Can you compare these very low abortion related physical risks to those associated with carrying a pregnancy to term? Because the major morbidity and the risk that we talk about in medicine include hemorrhage, severe depression, high blood pressure, diabetes, vascular issues, and even death.
Yeah, the complications that occur after a procedural abortion and a medication abortion can include infection, heavy bleeding, there can be retained clots or tissue, but serious complications requiring hospitalization or even requiring antibiotics occur in less than 1%. And compare that to an overall C-section rate in the US that's now around 31%. So in other words, carrying a pregnancy to term carries a risk in the United States, carries a 31% risk of requiring major surgery.
Mhm.
And Cheryl, you mentioned the risk of death. The term is maternal mortality, the risk of dying from complications of pregnancy, whether that be early in the pregnancy or later and immediately after. The rate of maternal mortality in the United States is the worst in the developed world and has actually increased in the past few decades. When I first began my residency a few decades ago, the figure that was being talked about for maternal mortality was around 8 per 100,000. It's now up to about 14 per 100,000. So it's actually increasing in the United States. And it's the maternal mortality rate is actually 3 times higher for Black women than it is for white women. This was brought home to me very starkly by something that's called the Turnaway study. The Turnaway study was a study that was done through the University of California at San Francisco Bixby Center. And what they did is they followed 1,000 women for over a 5-year period of time. Approximately half of those women presented for an abortion and obtained the abortion that they asked for. And about the other half presented requesting an abortion, but for one reason or another were quote unquote turned away, which is why it was called the turn away study. Usually the reason that they were turned away is because they were a little bit further along than the gestational age limit of the clinic that they presented to. And they followed both groups of women over a 5-year period of time. There were a number of results of this study, including that those women who were able to obtain the abortion they requested 5 years later were better off financially, were better off education-wise, were in more stable relationships, and a number of very good outcomes. But for me, the most stark result of the turn-away study was to find out that of the women who were turned away, 2 of them actually died from pregnancy complications. So this brings home that maternal mortality rate. And I think that there is a feeling in this country among many people that pregnancy does not carry the risk that it actually does. Mm-hmm. That you get pregnant, you have a baby, everything's fine. And that is not the case.
Okay, we've talked us through the surgical abortion. Tell us about medication abortion. We've had the ability to do this for about 20 years now.
Medication abortion, otherwise known as the abortion pill, it's a process that involves 2 different medications that are taken sequentially. And it can now be used up to 77 days or 11 weeks of pregnancy. It is also now the most common method of abortion in the United States. Right now, approximately 54% of abortions are done by medication. The first medication is known as mifepristone, also was originally called RU-486. And this blocks progesterone, and that's the hormone that supports an early pregnancy. It's a single pill taken by mouth, either in the clinic or by the patient at home. And the second medication is misoprostol, which causes uterine contractions. It's used for other uses in medicine as well. And those uterine contractions then expel the pregnancy. The woman experiences bleeding and cramping. And that cramping can be quite intense for a short period of time. And again, it's also extremely variable what women experience. Most women do very well with using ibuprofen for pain control.
Mm-hmm. Well, let's change course again and talk about something that you know very well, and that's residency training for how doctors are taught about contraception and abortion and complications that can happen with pregnancy and with birth control. According to the data seen here from the American College of OBGYN, family planning and abortion training is certainly not a given, either during medical school or during the 4-year OBGYN residency. Can you share with viewers your experience training OBGYN doctors about reproductive medicine and abortions and abortion meds?
There are 2 residency programs for obstetrics and gynecology in the state of Minnesota. The one at the University of Minnesota. There used to be 3, but the one at St. Paul Ramsey Medical Center, which is now Regents Hospital, combined with the University of Minnesota a number of years ago. And the other one is at Mayo in Rochester, of course. I was the program director of the residency program director at the program in Regents, and then, as Cheryl mentioned at the beginning, was the co-director when the 2 programs merged. That program now trains 9 residents a year, and there is a routine required rotation in family planning, which includes abortion training. Residents are not required to do abortions, although most of them choose to do so. And I even had a time when a couple of people over the years who initially said they weren't not going to train to do the procedure, and then decided to go ahead and do so after hearing some of the stories from the women. that they talk to, because all of the residents are required to learn the education that the patients go through, as well as the counseling and the consents, and to follow them through the process of both a medical and a surgical abortion.
Mhm.
There are also family medicine physicians also do abortions, as well as a number of other specialties. In general, they don't have a required rotation. There is one program in Minnesota. That's a family medicine program that has a required rotation in family planning, and that includes an abortion experience. And interestingly, I see on this slide that it says 51 to 54% of OBGYN residency offer abortion training. They are actually all OBGYN residencies are required to offer their residents the opportunity for abortion training. That does not, however, mean that the program provides that training. The resident is able to, if they want to and go through the effort, they are allowed to go and get that training elsewhere if they can. So it effectively is 51 to 54%, even though it is required that the training be available to all the residents.
Yeah, in this article, this is a little bit late, so there may be more states now, but only 5 states allowed APCs. Just means nurse practitioners and physician assistants able to do this, because as you showed us, this isn't technically a big surgical procedure that needs tons of medical years of training. And Minnesota does not allow anyone except a licensed physician, we'll cover that later, to do terminations. So that's something that's being looked at now. Well, now we have to move on to for doctors, the less interesting part, and that's the big abortion landmark cases. And we're putting these in because everyone, again, we think we know about Roe and we think we know about abortion, but the details sort of matter. And with the Supreme Court justices' hearings and so on, I thought some of this was rather interesting. So let's start with Roe v. Wade, 1973, almost 50 years ago. And Jane Roe was named a woman named Norma McCorvey, who was a single 22-year-old woman, lived in Texas, and had 2 kids. This was her 3rd pregnancy, and she asked for an abortion. And it was illegal in Texas. And Wade is Henry Wade, who was the district attorney of Dallas County. So his job was to uphold the Texas state law, which prohibited abortion except to save a woman's life. So McCorvey had to stay pregnant. She wasn't allowed to have an abortion. She sued. While the Supreme Court heard the case and deliberated, she had the child and gave the baby up for adoption. And the main takeaways in Roe were those things on the slide, that they used the due process clause of the 14th Amendment, stating that the woman had the right to privacy to choose to have an abortion. But there had to be a balance between the woman's health and prenatal life. So in Roe, the trimester phases were discussed. There was not to be any prohibition in the first trimester. There could be some reasonable regulations in the second, and there could be prohibition allowed in the 3rd trimester, as long as there were exceptions made for the health and saving the life of the woman. And then the other important part of Roe v. Wade was that the court said this was a fundamental right. And because it was a fundamental right, that required the level of strict scrutiny to be used for any future lawsuits. And that is the highest level of judicial review. And the court also stressed that the right to terminate was not an unlimited right, but the strict scrutiny was important. And the reason I bring that in is because when Judge Ketanji Brown Jackson's confirmation hearings were going on, I listened to several senators who brought this up. And that was basically them trying to ask her opinion on Roe, because that was an important part of Roe v. Wade. So the next crucial decision was Planned Parenthood versus Casey. And in this situation, Planned Parenthood was in Pennsylvania, which had very significant abortion laws requiring a waiting period, required the woman to notify her spouse before she could have an abortion, Younger than 18 had to notify both parents, regardless of what the family situation was, etc. So, with all of these laws, the um, challenge was to overturn those small things. And the court did overturn the trimester portion of Roe while they regarded all of these challenges. They also took away the trimester portions and went to viability. And so, with that as the new approach, that allowed states to start restricting first trimester abortions, and boy, did they ever! And we'll go over that. In addition, strict scrutiny was taken away, and the new standard became undue burden. So, this is a quote from the justices at that time, speaking to the personal autonomy issues of biology and family choices. And they upheld the essential holding of Roe. And what I've read about abortion since we've been preparing for this program was that most people really recommend that Roe and Casey are seen together because they are so intertwined. So, for years, decades really, Roe and Casey were the law of the land. Many states started to add laws to reduce access, which are the so called TRAP laws, TRAP, targeted regulation of abortion providers, over the last 10 to 20 years. Elected officials against legal abortion passed 288 restrictions to abortion since 2010, and that's a reference from Mary Ziegler's book. And then the court changed. And so, really, that's the main difference. Abortion was exactly the same 5 years ago as it is today, except now we have a different Supreme Court. And with Amy Coney Bryant being confirmed just weeks after Ruth Bader Ginsburg's death on September 18th, um, the Texas legislature came roaring through. So this Texas Heartbeat Act was signed into law and became effective this past September. Bans abortion after the detection of embryonic cardiac activity, which is about 6 weeks from conception, and the estimate is the embryo is about the size of a grain of sand at that point. And of course, I assume most people have heard that many people don't know they're pregnant by this time. The enforcement is not the law or state officers, it's members of the public, which is what made the Supreme Court deny a request for emergency relief of this from the abortion providers in Texas. There are no state officials to enforce this law. So, another case with the future of abortion now is the one that is before the Supreme Court now. This is Dobbs versus Jackson. So, Thomas Dobbs is the state health officer of the Mississippi Department of Health, and Jackson Women's Health Organization is the only licensed abortion clinic in the entire state of Mississippi, which has almost 3 million people. In 2018, Mississippi passed the Gestational Age Act, which banned all abortions after 15 weeks. And the abortion clinic filed a lawsuit requesting a restraining order, which was granted. And so now the question before the court is that Mississippi law banning abortion after 15 weeks constitutional? And the League of Women Voters was part of the many groups that filed briefs in support of the Jackson Clinic. So oral arguments were heard in December, as I mentioned, and then the bombshell happened on May 2nd, which was the draft written by Justice Alito was leaked to political reporters. And the draft does not say that they're going to uphold the 15-week ban. The draft says they fully plan to reverse Roe and Casey, that they were egregiously wrong. Along with Alito, Justices Thomas, Gorsuch, Kavanaugh, and Coney Barrett evidently agreed. The last three, of course, were appointed by former President Donald Trump, who had openly campaigned that he would appoint justices who would overturn Roe. Justice Roberts has not indicated his vote yet, but he did confirm that the draft was authentic, and that's all we've heard so far. So, Dr. Ball, my impression is that many in the abortion and reproductive health care systems did expect this decision, although we'll stress again, this is the draft, this isn't the final decision. It's the preliminary text. The actual decision is expected in a few weeks, maybe as early as this Memorial Day weekend. The leak was an incredibly difficult surprise. How do you view this?
Well, most of those who are work on the legal side of the reproductive justice movement, and were following these cases in the courts, had been warning us for quite a while that the decision in Jackson versus Dobbs would certainly significantly decrease the protections provided by Roe versus Wade, if not directly overturn it. I mean, I think that they were trying to prepare us for this if any of us were holding out any hope whatsoever. Still, the harshness and the language of the leaked opinion was a shock. I have not read it myself, mainly because I heard that it makes for very difficult reading. I heard one person who did read it say that they did not recommend it. And I also understand that Alito's opinion quoted a judge from the 17th century a number of times. Gates, I think, might have been his name. I can't remember for sure. And this is somebody whose opinions for many years were used to say that marital rape could not exist. This is a period of time when we were burning women as witches. And he was quoted 8 times in Alito's opinion.
Yeah, and it also said that abortion's not mentioned in the Constitution, but many commentators have said women aren't mentioned in the Constitution. We weren't really legal citizens. We couldn't vote. We couldn't own property, and we were not mentioned specifically. So, well, since the leak, um, there has been all sorts of media. For the last 3 weeks, it's been just exploded. And I've seen some reporting about Minnesota that we're safe because we've got this, protection in our law. So I wanted readers to know something about this case, Doe versus Gomez. This is Minnesota law now. When the lawsuit was brought by all of the women in Minnesota, represented by Jane Doe. I didn't realize that I'd been in a lawsuit, but evidently I had. And this challenged Minnesota's laws prohibiting the use of state funds for abortion services. The state paid for prenatal care and childbirth, but refused to pay for abortion. So in the lawsuit, they said that's not fair. And the Minnesota Supreme Court basically agreed that it was unfair to pay for one medical scenario and not the other, because that doomed a woman to a certain medical outcome just because of government rules. It was unfair for the state to put its finger on the scale. So it's true that to undo this, it would require either an amendment to the Constitution or the court overturning the decision. Um, but I don't know, with the shock of the leaked draft, I don't know that I feel all that secure in Minnesota just because of this lawsuit. Do you have any comments on that?
Well, as we are hearing about what will be the aftermath of the new Supreme Court decision, if Roe versus Wade is overturned or severely restricted, there are maps being put up that show which states have protections for the right to choose and which do not. Minnesota always comes up as one that does have constitutional protection. However, as with Roe versus Wade, all that someone would have to do would be to begin a lawsuit that would then go up through the courts and allow the court to overturn Doe versus Gomez. Now, our court system does not have the same makeup as the Supreme Court currently does in terms of the very extremely conservative judges. However, it does give one pause to think that this also could happen in Minnesota. It would take some time. It's taken a number of years for this to happen on the Supreme Court of the United States. So it also would take some time for a lawsuit to make its way up through the court and have Doe versus Gomez overturned.
Well, I'd like to share for those in the audience a lawsuit that's currently pending in Minnesota. And this lawsuit is taken by an OBGYN in Minnesota that is identified as Dr. Jane Doe, and I think she's a nurse midwife, certified nurse midwife, who's identified as Mary Moe, and the First Unitarian Society of Minneapolis, and a nonprofit called Our Justice, which supports reproductive health decisions. So this lawsuit is against the state of Minnesota and others, specifically about the trap laws, saying that they are out of date and discriminatory. So, Dr. Ball, could you talk to us a little bit about? I've got, I think, on the next slide, some of them. These are the things that any abortion provider has to deal with. These are all legislated by the Minnesota government. Um, for instance, when a woman comes in for an abortion, she has to fill out information about her age, marital status, race, income, education. All of that data comes from a form that has to be filled out, correct?
Yes, the patients have to be asked many questions, and one particularly egregious one is why they are choosing to have an abortion. And as you mentioned, only licensed physicians can provide abortion care, including medication abortion, which does not require a surgical procedural skills. And also, as you mentioned before, Dr. Bailey, those are procedural skills that nurse practitioners and physician's assistants are perfectly capable of obtaining. There is a lot of reporting that needs to be done to the state, and an annual report comes out every year that says which a number has a long list of physicians who are all by numbers. No, there are no names, and how many abortions each one of these numbered physicians performed. The age of the patient, her parity, how she paid for the abortion, things like that. And it results in I think you said 82-page report, Dr. Bailey, that I sent to you that has to go to the legislature every year. So this requires a lot of time and effort on the part of the clinics, and also a lot of time and effort on the part of the Department of Health to put together this information and present it to the legislature. And there is no other medical procedure that is regulated in this way.
Right. Colonoscopies, I mean, imagine if people had to fill out 9 pages of information about how they were paying for their colonoscopy, and then the GI group would have to report how many that they had, etc. The other thing that's chilling is a lot of the laws that are written make infractions, really seemingly small infractions, felonies, and I think that's intended to strike fear. That's the same with the Texas legislation. One of the felonies, one of the infractions is if the clinic doesn't keep that consent form for 3 full years. If someone should go and try and find a person who had an abortion 3 years ago in a day, or 3 years ago minus a day, and it wasn't found in that clinic, that could be a felony for that infraction. The other thing is that if patients come in for a second trimester termination, they often have a fetal anomaly, and they've made that difficult decision to terminate because the fetus cannot survive after birth. And the state requires us to tell them about perinatal hospice. Do you have any experience with that?
I do not. I know that I do not have any personal experience with that. I know that they need to be informed that perinatal hospice is available, and some patients choose to continue the pregnancy. As you talked about, Dr. Bailey, your residency fellow who had the child with where the left ventricle didn't form. That person would have had to be informed that they could continue the pregnancy, and then there would be hospice to care for the infant until it died.
Yeah.
So, and it is something that's available. So.
And then let me get to our last.
Well, I wanted to talk about some of the things that are in here. Some of these are the ones that are most egregious to me anyway, are the one about informing both parents if the patient is under 18 years old. It's not parental consent. You do not have to get the consent of the parents, but they have to be informed. And even if one of the parents has never been involved with the child, if it's known that that other parent is alive and where they might live, that parent has to be informed as well. So it's two-parent notification, and
Mhm.
that can be very difficult for a family of a young person who is going through this experience. There is judicial bypass, but that means that somebody under the age of 18 has to go before a judge and be judged to be mature enough to make her own decision, basically. The other things are the 24-hour delay, the 24-hour wait, informed consent, also known as the women's right to know, so that every woman, every person who calls for an abortion appointment has to receive certain information at least 24 hours before the abortion is done. So it creates a delay, which can be a really big problem in some cases.
And I think that in South Dakota, the person doing that counseling has to be the same person doing the abortion the next day.
Well, actually, in South Dakota, it's 72-hour, and yes, it has to be the same person. It has to be in face to face.
Yeah. So
That's in
people
South Dakota. Yes.
people traveling to South Dakota have to be there, and then 3 days later have to be there. It has to be the same person. The doc can't have a cold and call in sick and have a different colleague. It's got to be the same person. There are other laws that have been passed or at least attempted that made the hallways of the abortion clinics a certain width that would allow a gurney to get past when there are no gurneys used. Gurney for non-medical is those big unwieldy carts that people lay down in when they're recovering from general anesthesia, and we don't use those because people are not anesthetized for this.
Yeah.
Or hospital admission privileges for a procedure that does not lead to hospitalization. And if it did, it's usually quite a bit distant from the procedure itself and really wouldn't have any bearing on a procedure days earlier. So those are some of the things that are being legislature, and this is what the current lawsuit is targeting, and that is decision is supposedly June or July will be out. And then my understanding is that the laws that were passed that were the same verbiage as the Texas laws got no traction in the Minnesota House. They've just finished their work as well. They've closed up shop as of midnight on Sunday, and that none of those laws passed. So I think we have one last slide here. And this is from Mary Ziegler's book when she says that she really doesn't see, regardless, and this was again published 2020, so it was 2 years before this all happened with um, the leak and so on. She even if the court reverses Roe, battles in each state, the conflict will continue to escalate. And if we believe the Supreme Court bears most of the responsibility for the state of the abortion debate, or expect things to improve automatically if the court removes itself from the equation. This last slide shows what's going to happen if Roe v. Wade is overturned. Can you just talk about what you what your thoughts have been and what you've heard from other people about kind of the immediate aftermath in our states and in our country?
Well, there's a lot of discussion going on about, and there has been for several years, actually, knowing that this sort of thing was very likely to happen. It has been, excuse me. This kind of discussion has been going on about what will happen in a post-Roe world. And as you can see, here's one of those maps that I was talking about where Minnesota is a protected state, and we are surrounded by states that will either immediately or likely very shortly after Roe is gutted, make it illegal to have an abortion in their state. North and South Dakota will immediately, it will be immediately illegal. And so what will happen is most likely is that women will have to travel. And there are networks being set up, as there are in Texas right now, to help women in Texas go someplace else to get an abortion. So those networks will have to be hugely expanded to help women travel to other places. We are in a different situation than we were before Roe versus Wade, in that we do have medication abortion, and trying to figure out how to get women the medications that they need with the proper instructions that they need is also going to be another part of the solution. But Minnesota is expecting an influx of patients from surrounding states, most likely. And we at the moment are not, we will not be able to handle those numbers.
I'm just going to end this with a screenshot from the league's national website, and I'm going to quickly look for some questions because we have about 5 minutes. If we could answer some of these, let's see. We have a question regarding crisis pregnancy centers. The readers or the viewers' impression is that they deceive pregnant people to delay until the pregnancy's moved into another trimester. And the viewer mentions that these crisis centers receive a lot of tax dollars. Do you know anything about that? Do you have any info you could share about that?
It's very clear that crisis pregnancy centers lie to women. And there's a lot of literature out there that talks about that. I'm not familiar, and I'm sure it varies from state to state as to how much money crisis pregnancy centers get from the state. I don't know what they get from the federal government, but I think that they do get some support in some states.
And then here's a question. One of the recent advances in medicine include non-invasive prenatal screening, followed up by additional diagnostic tests. Ideally, this screen or test will allow a family to make a choice with reference to severe genetic disorders. Will this type of screen and test still function within the timeframes that are being suggested by new state laws?
I do not know the answer to that. Generally, what has to happen for these tests to be accurate is it is a blood test drawn from the mother. There are fetal cells circulating in the woman's circulation, and they do the tests on those cells, somehow detect them. So I don't know what gestational age has to be reached in order for that to be the case. That's not something that I have expertise in. It is nice to be able to find out earlier than you can with an amniocentesis. And amniocentesis is the earliest generally can be done is about 18 to 20 weeks. Mm-hmm. And that has been happening more and more, but I don't know the lower limit. Certainly not 5 or 6 weeks.
Not 5 or 6 weeks, because people often don't, they've just barely missed a period, so.
Right.
Another question was, have there been any right to know requirements for men? And I don't think there's any procedure, any surgical procedure for men or women that require ultrasounds or other things that the person has to look at, etc.
I'm certainly not aware of any.
No, I'm not aware. A question was, are the medication drugs available in Canada and in Mexico? And I'm quite interested in what medical boards will do with prescribing abilities, and what state legislators will do if they are making it illegal in their state. Will they make it illegal for a patient to receive a pill in their own mail, in their own post office, delivered to their own house?
I'm not sure about Mexico. I'm pretty sure that they are available in Mexico. Certainly misoprostol is available because misoprostol is used for other things. Mm-hmm. Mifepristone is manufactured by a I think only one company, and they have pretty strict prescribing requirements, which we're trying to get rid of. And the FDA also has what's called REMS, and I can't remember what that stands for, and we're trying to get rid of that as well to make mifepristone more available. Canada, it took a long time for Canada to get mifepristone, but as my understanding is that they do now have it, yes.
Maybe one last question before we close, and that is, we often ask if you have a call to action for viewers, is there anything that you can think of we can specifically lobby our legislatures uh, to consider doing to protect reproductive rights and to um, respect the autonomy of adult women?
Well, I think the most important thing is to pass the Women's Health Protection Act, which would be a national law protecting women's right to choose, and also to pass that same sort of legislation in Minnesota. Because what we need to do is we need to, as Amy Klobuchar says, codify Roe. We need to put it into law and not have it just be a court decision.
Mhm. Um, Thank you. I think we're at 8 o'clock and we've had our chance to go over this. So I'm going to give the viewers a quick rundown on important voting dates coming up. August 9th is the primary, and so very shortly you'll have the chance to do early voting. And please join us for our next program on some extraordinary women in St. Paul, again on Zoom and Facebook Live, Tuesday, June 28th. And Dr. Ball, we cannot thank you enough for participating in this, for being an expert panelist on this topic. I just so appreciate you saying yes to this and helping us understand this.
Oh, it's been my pleasure. I was happy to do it.
Thank you. Also, thanks to the supporters from the White Bear Lake area and the Roseville area leagues and the SPNN and the suburban community channels. And to you, thank you so much for watching. We appreciate you coming. We appreciate you asking questions and thinking about this topic. If you wouldn't mind, there'll be a short pop-up quiz when you log off. And if you could give us a minute or two to answer those questions, we do read your answers and try and think of new programs based on what you say. So again, thanks to all of you. Have a wonderful evening.